This session is titled Overcoming Common Barriers Around the Application of Immuno-Oncology in Community Settings. And we have the panelists up here. I'm going to have each person actually introduce themselves. So starting with Mamatha.
So my name is Mamatha Chivukula. I'm a breast pathologist by profession, but I'm also a director of immunohistochemistry lab and breast pathology services at Sutter Healthcare System in Northern California. We're very close to San Francisco City. So, and I also have a older academic affiliation and associate professor from University of Pittsburgh Medical Center. So,
hi, I'm Lisa Haley. I do assay development at Johns Hopkins in the molecular diagnostics lab. We do somatic molecular testing for our clinical specimens, our affiliates, and outside consult cases. With regard to immuno-oncology, our lab does an MSI-PCR test as well as a large solid tumor next-gen panel, which includes CNV and also our newly validated TMB assay.
Hi, everyone. I'm Stuti Shroff. What I will be having with regards to this panel will be pertaining to my experience at the University of Pennsylvania. I was there for 5 years, and I was signing out predominantly GI pathology. And we did do a lot of molecular tests. There are a lot of requests for MSI as well as for assessing the next-gen sequencing results that were done for various patient panels.
Great, thank you very much for those introductions. I have to go through and just read the disclosure slides. So you'll see that over the past 12 months, neither Stuti, Lisa, nor I have any disclosures. In the case of Mamatha, she's received honoraria from the advisory board as well as relationship with Merck. So these are the faculty disclosures. You can also find more information in your program book. And today is going to be a very interactive discussion. We don't want to be up here presenting data and slides to you, but rather we're going to have discussions and questions for you all, so that's why we've got these keypads in front of you. And you'll see the outline, in terms of what it is that we really want to cover. There's so much happening in the world of immuno-oncology, and we want to dive into the ways that pathologists are becoming more actively engaged in all of this. What's happening at the pathology level, what's happening at the lab level, and then how does all of this apply in the community setting? What does this mean? So those are some of the issues that we're going to be discussing. And we do want to hear from you as well. We want to get questions from you and have input from you and also hear from your experiences. And we know that this is an area that is rapidly evolving. And so even some of the material that we'll be talking about might be a little bit outdated in that, just over the last few weeks, there have been additional indications and drugs being approved. Just to set a little bit of context, in 2016, ASCP formed an immuno-oncology working group. And as a result of this working group, we've now developed a series of these educational projects. So you've probably received emails on some of these IO-related topics. And the goal was really to address what are the educational needs, but in addition to that, what are sort of those system-level barriers and issues? It's one thing to know the science, it's one thing to know the clinical information, but are you able to apply the kinds of changes that you want within your own organization? And if you can't, then are there ways that we can possibly overcome some of those systems barriers? And so we focus a lot on QI, quality improvement. We also focus on implementation science and really engaging the entire multidisciplinary care team. Several months ago, we had an opportunity as part of this broader project to work on a project called IO, or Immuno-Oncology Changemakers. And part of this focused on not just the clinical and scientific and technical aspects of what's happening in the immuno-oncology space, but really looking at some of those adaptive challenges. So we addressed things like, what are the practice patterns in an average community hospital where you may have, for instance, different medical oncology groups who desire different things and have different requests, and perhaps the pathology services is centralized. How do you sort of navigate those waters? And what's happening in the landscape of biomarker testing, what's happening with things like PD-L1, and that's what we're going to get into, PD-L1, MSI-MMR, as well as things like next-gen sequencing, tumor mutational load or mutational burden, and the complex and operational issues. So this project had some pre-work, some reading assignments. We then had a series of these live interactive discussions where we heard from people all around the country about what's happening in their hospital, within their cancer center. And then we also had some post-activity work with some feedback. And ultimately, these were the themes that kind of emerged from those discussions. And these are the same themes we're going to be tackling today. So how do things like the cost of testing, reimbursement, how does that factor in? Where does turnaround time come into play? Some of these tests the results may be available in a few days. Others might take potentially a few weeks. So if that's the case, how are we working through all of that? Is there understanding of what the tests even mean and how to interpret these results? And are they clinically actionable? And are patients being led into clinical trials, for instance? So there was a lot here in terms of just coordination as well as communication engagement with the cancer team. But one key theme and trend, I think, that's emerging more and more is how can pathologists play a more active role in all of these discussions? How can they possibly lead and even guide and counsel their clinical counterparts, the medical oncologists, surgeons, those performing biopsies, around many of these issues, and ultimately making sure that patients are receiving the most appropriate care. And we applied this framework, which some of you may be familiar with. It's called the Adaptive Leadership Framework by Heifetz. And essentially what it does is it reminds all of us that in something as advanced as immuno-oncology, there are clearly technical and scientific challenges, issues where the evidence clearly says this is black, this is white. Perhaps there are some controversial issues that are gray, but a lot of scientific debate and discussion. And you can pull up different studies to show and prove your points. But then there's a series of these adaptive challenges, things that are really intrinsic to human beings as part of the process, or systems level issues and challenges that you may face, where there is no clear solution, where the solution for one center might be very different from another center. And so ultimately, you may have to do a little experimenting. You can certainly learn from your colleagues and your peers, but there's not always going to be a scientific method or a formula in terms of solving some of these adaptive challenges. So having set the stage now, I want to ask you all to pick up your keypads and answer this question. Rate your level of confidence matching the different immune checkpoint inhibitors that's on the screen, and there's now one missing because one just got approved last week. But what is your level of confidence with the list of drugs, and do they target CTLA-4, PD-1, or PD-L1? Are you not confident, minimally confident, moderately, or very confident? So please make your selection, and we'll give it a few seconds for everyone to sort of click in, and then we will show you the responses from this room. So give it just a couple more seconds. Hopefully everyone's had a chance to click in. All right, so let's see what kind of responses we got here. Okay, so 42% saying not confident. Thank you for being honest. 8% saying minimally. 33% saying, yeah, I'm moderately. And 17% saying, yeah, I'm very confident. Fortunately, it's a fairly short list of drugs, but I think one thing that is more traditional is in many cases, pathologists in many organizations, and I don't want to generalize here, but in many organizations, pathologists haven't been as up to date or have wanted to learn necessarily about drugs, drug names, drug mechanisms of actions in many places. Now, perhaps you are in a place where that's different, and I hope that's the case. But I think in the landscape of immuno-oncology, there's that growing importance to make sure that you are learning and that you're up to date so that when you're speaking with your medical oncology colleagues, that you really understand and you can even make potentially some recommendations. So here is sort of the answer, if you will. So IPI is the CTLA-4. It's been around for a very long time. A lot of melanoma treatment, for instance. And then we've got the two PD-1s, Pembro and Nivo. Another PD-1 just got approved last week for cutaneous squamous cell. And then 3 PD-L1 inhibitors. And it's often very confusing, PD-1, PD-L1, and we're going to get into some of the testing issues behind all of that. Let's ask one more question to the audience. As of October, so here we are in October, which of the following PD-L1 tests are FDA approved as companion diagnostics? So take a look at this. Go ahead and vote. Which of these are FDA approved companion diagnostic tests? And we'll give it a few seconds, let everyone chime in with your answers. few more coming in, so. All right, let's see how people responded. Okay, so 29% saying 22C3, 50% saying 22C3 and SP142, and then sort of 21% with option 3 and 0% picking the final option. So the correct answer was that 22C3 and SP142 if you were up on the latest news from just August. So this is still very, very new. And if you can imagine just trying to keep up with all this information, it can be quite overwhelming for a lot of people who are having just a hard time with so much data as well as updates and approvals. But we wanted to cover this because for a long time everyone's been talking about 22C3. Now with SP142 in there, what does that, how does that change the mix? And then if you're possibly even bringing in a lab-developed test into your own lab, what does that mean? So part of our discussion today is going to be around, companion diagnostics, we know that. But what about complementary diagnostics and exactly how is that being used? What do the payers want? What are they expecting as it relates to some of these tests? So the three topics that we're going to cover, and really we want to engage in discussion with you all, are around these three biomarkers. First, the PD-L1, what are the issues there? Secondly, and we're going to use a lot of acronyms today, but NGS or next-gen sequencing, the role of tumor mutational burden or mutational load, as you may sometimes see it written out. MSI, microsatellite instability, or MMR, mismatch repair. Where do all of these things fit? What level of testing is appropriate or standard of care in community settings that are not necessarily driven by research or clinical trials? And what's happening in your neck of the woods? Essentially, what are things that you can possibly go back home to apply and implement within your own centers? So with that intro, we're going to talk and dive into the first topic, which is PD-L1 testing. And we want to set up a case scenario. We want to sort of come up with a fictitious example. So suppose that at a recent cancer committee meeting, several of the physicians mentioned that, our lung needle biopsies, we're still running into the quantity not sufficient, the QNS problem. We're ordering all these molecular tests, and we just don't have enough. And they come to you and they say, what should we be doing about our molecular testing as well as PD-L1 testing? It's not like we've got a huge sample of tissue where we've got so much we can do all the testing we need. We have to be sort of mindful of what quantity we have to work with. So then this leads to discussion about all the different types of PD-L1 tests, like the ones we just referred to earlier, as well as all the reference labs. What are they doing? What are they communicating and marketing? How are your medical oncologists ordering and requesting these tests? And in this particular example, you work in a pathology lab, and you're currently sending the samples out for testing. So the samples are being sent out, you're getting the PD-L1 testing as well as the interpretation that way. That's the case. We want to ask you, does that relate to you? So take a minute now and answer this question of how do you currently perform PD-L testing in your own hospital, cancer center, lab? If you're performing PD-L1 testing, do you send all samples out? Do you actually perform and interpret the tests in-house? Or is it a mix where some samples get sent out, some you're doing in-house? So go ahead and click into your responses. And if you're not sure, you can vote for. But we're hoping that everyone knows how PD-L1 testing is being done. So we'll give it a few seconds and let everyone respond, and then we'll have some discussion about this. All right, hopefully everyone's had a chance to chime in. So let's see how people voted. All right. So a little over half are currently sending all the samples out. And there's a significant percentage that are not sure, and that's fine. This makes sense because, obviously there's a lot of different tests to keep up with. And 14% saying, yeah, it's kind of a mix. Sometimes we send things out, sometimes we test in-house. So now I'm going to turn to the panelists and ask the question of, how's PD-L1 testing done within your institutions, as well as what are some of the key issues and challenges associated with this? It's not as simple, perhaps, as what some people might think. So Mamatha, let me start with you and just share with us what's happening in your center.
So I represent a huge community or a hospital-based practice. So right now, currently, we are sending out all the PD-L1 testing out to a outside laboratory, and the results come in, and we do scan the reports, and we scan it into the EPIC chart where the clinicians review the report. We started validating the PD-L1 in our in-house. And we'll be starting off as a laboratory developed test. The problems that we have been having the issue to 1.5 years ago kind of minimized because I think if you read your CAP newsletters, Dr. Sanya Desik and from Memorial Sloan on the Medscape and all this lung community has got together, and they're also understanding the problems having multiple clones outside and the confusion for the pathologist which clone to pick and what machine are we supposed to be running. So these are the issues that we had, and that made the pathologists in the community setting not to deal with any of these hassles of validation and just send it out and let them deal with it and get the report and give it to your oncologist. So it's changing now, and I think the new CAP letter also mentioned an article that we have to come together as pathologists and we should be the people to make the choices as a laboratory developed testing. And to me, the key issue is the validation process. And when I talk to, I feel like the hospital that I'm working, Mills Peninsula Hospital, is tucked in between UCSF and Stanford. So I do contact them and try to see what's going on in both the places to have a comparison. And what I did with my validation process was not every hospital or any laboratory will have the DACO system with the AutoLink. So the true FDA approval is for the 22C3 on the AutoLink. And we have Ventana, we have Bond, and so we should be able to run the PDL1 on different machines, and we should be able to strengthen our validation system process. So what we did was we validated on our Bond. And what I did was I took the same cases and tested it on the AutoLink, and our concordance rate was 98 to 99%, which is pretty high. So to me, I think that's good enough validation, not just for me, but for any community pathologist to be happy about it and bring it as an in-house laboratory developed test. The second problem that we are encountering is how to report this. So now that the new recommendations have come for GI, cervical, and bladder is quite different. We have the cumulative score and quite different from the lung that we are using. So we are creating 2 generic reports that would include the cumulative score versus for the lung, we're going to have a general score of what % of the cells are positive and the strength of the staining process. So we're still in the process of doing that. And I keep on looking on the CAP website if there is anything that would direct us towards a standardized report. But I think we're not at the prime time yet for this standardization of the reporting system. But as long as we communicate with our oncologists and also put in the correct the trial data and everything that would help the oncologist to take a look at. After all, when you're talking about it, it's still an immunohistochemistry stain. But I think there are few more things that we need to know from others as well is the heterogeneity of the PDL1 expression. What are the correct samples that we should be performing? And what do we do when it's negative? And the metastatic setting, the bony samples. So there are many other issues still we have to review, and a lot of information needs to be pulled up from every institution and get the cumulative data that would help us to implement the PDL1 much more successfully. So.
Great, thank you, Mamatha. And Lisa, what about your experience in your role at Hopkins? Tell us about it.
Well, our lab specifically does not do PDL1 testing, but the PDL1 testing at Hopkins is done in-house. And it's critical knowing from an interpretation standpoint, tumor type is such a factor. I don't have direct experience because we don't do the testing, but lung, colon, breast, all of the samples that would be eligible for immune oncology checkpoint inhibitors that's the frontline test that's done.
Great, thank you. And we'll certainly get into more questions related to molecular and talk specifically about what's happening in your lab. But Studi, what about in your experience?
At the University of Pennsylvania, the PD-L1 testing was done in-house using the 22C3 DACO system. And so with regards to the key issues, primarily with the recently approved testing for GE junction and gastric adenocarcinomas, we found, in addition to what Mamta alluded to in terms of tissue heterogeneity, what we found was that when we performed this testing in-house, that compared to what has been reported in the CheckMate trial, the percentage of tumor cases that were getting a combined positive score of greater than 1 was a lot higher than what had been reported as what should be expected. And so that always raises the question is, how valid is this test in terms of whether this is going to be actually representing, because sometimes you would see only staining within some immune cells and not really within any tumor cells. So that was one of the key issues. The other issues that we have come across is that we're getting a lot of requests from clinicians for testing PD-L1 within non-approved tumor types. And how do we report those? Because there is hearsay that the combined positive score is going to be used for reporting those tumor types, but until such thing has been validated and set out by the FDA, we're just reporting the proportion of staining that we're getting within the total proportion and not really giving an interpretation of what that staining actually means. So that is certainly one of the other testing that challenges that we come across within our realm of cases that we encounter, the patients that we encounter.
Great, thank you very much. So we're just going to review a few things real quick. I think the landscape of PD-L1 testing today is so hard to keep up with, primarily because you go to certain websites and you look at their tables and charts and it's already outdated. This is something that we've just sort of taken and we've adapted from a reference lab and essentially had to add the fact that, okay, well, this test used to be complementary, now it's also has this companion indication, if you will. And the numbers and the list keeps evolving. And as Studi mentioned, the second column there lists specific indications like non-small cell lung cancer, gastric or GE junction, melanoma. But what happens if someone requests it on a different type of tumor? Then how are you supposed to report that? As well as, this is just a real quick review, if you will, on things like tumor proportion score, TPS, versus that combined positive score, CPS. And, PD-L1 is not simply just positive or negative. And I think there's a lot of confusion about, how do we even interpret these results and then use that information to, prescribe and treat patients with these immune checkpoint inhibitors. The other issue that we hear over and over is that when it comes to insurance companies giving prior authorization for these therapies, they may request certain tests. And so as you think about institutional policies, procedures, it's one thing to look at the FDA label and say, all right, there's a companion diagnostic requirement versus this I can use without that companion diagnostic requirement, but is the insurance company going to request a complementary diagnostic test? So I think these are also issues that further complicate this topic of PD-L1 testing. I want to open it up and just give all of you an opportunity to ask the panelists questions on this topic of PD-L1. And if we don't get any questions, then we'll move on to the next series of topics before we come back. But does anyone in the audience have any specific questions regarding this whole topic of PD-L1 testing and its use for immune checkpoint inhibitors? Yes, and if you could just really speak up.
So, there's so many questions to ask, actually, but I won't monopolize the time. So, I'm also in a very large community hospital with the largest cancer center in the state that I'm in. And we have experienced great challenges and frustrations on the very basic, implementation of reference laboratory, a very large reference laboratory nationally. And all those samples are then basically mandated to go in that direction. And we're not just doing PD-L1, we're doing lots of different tests, if you just take lung as an example. And those samples are actually going different places, in different places of the country. So you can imagine the frustration the oncologists have with getting the feedback information so they can deal with their patients in a timely manner and treat them appropriately. So we're really trying to figure out strategies where we can minimize the delay in turnaround time, do an IHC stain, which we do who knows how many of those already in our lab, and just trying to implement that and working with our administration to get that test in-house. If you guys could speak to that, especially maybe the first speaker there that actually brought that in and how you navigated that from the business standpoint, that would be really helpful.
So they're very, very important questions that you're asking, and I do understand the challenges you're facing. Fortunately, our group doesn't belong to where the oncologists and the hospital are working in different directions and having different laboratories. So we work with only one laboratory. That makes our lives easier. But what I did moving to California 7 years ago and working for the past 2 years was to bring in all the hospital systems from Sutter Healthcare together, having a pathologist from each of the laboratories to represent a group that we created, a task force group, to come together, talk about the problems that we have. And because every group is different and every group has a different oncology groups, and that would need different testing. And some, as you said, some of the oncologists would like to send it out to certain laboratories. So one of the things that we did was to involve our lab managers, which, one thing that you can do. And to sit with the, what we did was we divided the patients into Medicare and the non-Medicare reimbursement processes, and we did run a quality measured study for almost like 6 months, 1 year, take how much period you want, and go through the reimbursement stuff and how many patients have been reimbursed or, going through a quality check. And we also looked at the turnaround times from the different laboratories that we were sending out, particularly for the EGFR, Alcross, for the NGS testing. And we also, what we did was we sat with our oncologists and showed them the data. And, and we also did literature review and brought in some literature that's, and also having a big hospital system, like quoting some of the hospitals that have looked into these issues and talked to them about it. And our laboratory manager, actually, we do have another panel discussion on Friday afternoon. If you can make it, my lab manager, she's presenting here. She has all the data on how they have talked to the administrators and they have come to and we also worked with the Foundation Next-Gen Sequencing people and come together, because part of this, everything is driven by cost. So, as you know, so that's the most important. It doesn't matter which hospital laboratory you're sending, but cost is the main thing that everyone is looking into. So we also worked with the foundation to come to a pricing that would be amicable and to the hospital administrators as well as to the oncologists as well. So these are some of the things that really helped us, towards this process. So,
Thanks, Mamitha. Yeah, we know that this is a very complex issue and it's not going to be a simple or short answer, but I think some of the topics we're about to dive into next, I think will also overlap with some of the similar issues and themes, because some of these tests are done on the same sample, and if you need to split that sample or send it to different labs, it does complicate things. So for the sake of time, we're going to move on to this next topic of next-gen sequencing, the molecular testing. That's what we're referring to here, broad genomic profiling, as well as this emerging biomarker called tumor mutational burden. And as I mentioned earlier, sometimes you'll see in the literature mutational load, or ML, but TMB seems to be the term that a lot of people are starting to use. We are going to get into some of the cost-related issues and some of the policies. So take a moment now and pick up your keypad. what is your level of familiarity with the Medicare to CMS national coverage determination for next-gen sequencing? This is very new and very recent, but indicate whether you're not familiar, minimally, moderately, or very familiar with this. We'll give everyone a few seconds. Please key in your vote. So once again, this is the Medicare, the National Centers for Medicare and Medicaid Services, CMS, their national coverage determination for NGS. Let's see how people responded. Okay, so kind of, polar opposites, if you will. A lot of people saying not familiar at all, a lot of people saying very familiar, which is great, and then, a mix of people kind of in between. We're not going to spend too much time diving into this topic because there's a lot of information and there are still many unanswered questions. But essentially, Medicare finalized coverage for NGS, and this announcement came out last year in November, and then in March of this year, they finalized it and provided a little bit more detail. And essentially what they're saying is that, yeah, for Medicare beneficiaries, Medicare will cover NGS for molecular testing for patients who have advanced cancers. And they're defining advanced as recurrent, metastatic, relapsed, refractory, stages 3 and 4, or stages 3 or 4. So it's not only stage 4. There's obviously a lot of repeating and sort of overlapping terms there in their sort of IE brackets. But keep in mind that this is something that is probably going to fuel more testing, also fuel a lot more excitement, but at the same time brings up a lot of questions. What about repeat testing? What happens if someone gets recurrence of cancer and so on? So I think there still remains many unanswered questions, but if this is not being actively discussed within your own settings, then I would encourage you, make sure you start a discussion or lead those discussions. Get involved, because this is definitely something that's going to change how testing is done. So we want to present another case. And we came up with this fictitious name, River Hospital. Hopefully none of you are from an actual hospital named River Hospital. But we're going to say here that River Hospital has a cancer center. You've got 2 different private medical oncology groups. And they each have their own different philosophies around molecular testing. Group A sends most samples out for NGS. They're willing to take that extra time and wait. They want to get that comprehensive genomic profiling, look for alternative driver mutations, possibly enroll patients into clinical trials, and if patients have a targetable mutation that perhaps isn't necessarily on label, they're willing to explore that. Group B, on the other hand, rarely requests NGS. They pretty much just stick to what they consider standard of care, as well as whatever is FDA approved. And only rarely will they actually request an NGS test. So, at a recent Cancer Committee meeting, the different medical oncology groups happen to be discussing this recent CMS national coverage determination for NGS testing. And several mentioned that, hey, have you heard of TMB? This new biomarker called TMB is really emerging. And you know what? It seems to better predict how patients are going to respond to immune checkpoint inhibitors, possibly even better than PD-L1 testing. And in fact, maybe it'll replace PD-L1. So there's a lot of debate, a lot of discussion, and a lot of sort of puzzled looks, because many people really don't know much about TMB or where this is going. So how about you all? What about this room? What is your level of familiarity with TMB? And just take a moment to punch in your responses, because we want to see, based on your level of knowledge, expertise, as well as what you've been reading in the literature, are you not familiar, minimally, moderately, or very familiar with this acronym TMB? So please take a moment to vote. Got a couple more seconds. And let's see how people responded. Okay, so mostly saying either moderately or very familiar, but still 21% saying, yeah, I'm not familiar with this acronym TMB. So we want to get into this issue of TMB and next-gen sequencing. I think there's probably a lot of confusion and overlapping information about this topic and this acronym. So I'm going to start this time with Lisa. Tell us about your molecular lab, the testing you're doing, as well as what does TMB mean within your institution and within your molecular lab?
Well, like I said, we recently validated a TMB assay using our 400 or greater than 400 gene hybrid capture panel, next-gen panel. The motivation for that was that our oncologists are asking for it. They were sending this test out, and our institution, most of our tests are done in-house, but this was a test they were sending out, and that increased turnaround times and cost. And because we had a panel of a size that could achieve basically the same results of the send-out test, we chose to validate that. That being said, we are currently reporting tumor mutational burden, which is stratified into kind of a high, intermediate, and low call. We do quantify it. We do get a numeric TMR value, but I think the clinical relevance for all these different values is still to be determined. We modeled our validation off of the algorithm from our send-out test, basically, and so we compared our results to previous results that we had gotten from that outside lab. In addition, in our validation, we looked at our colon results for MSI high, MSI results in general. We had 100% concordance with our MSI high results and our MSI low results. The region of our TMB where we considered intermediate, there were a couple of highs, a couple of lows, and then there were situations where both MSI and MMR had given C findings types inconclusive results. Certain tumor types can give inconclusive results with MSI. There are false positives and false negatives with MNR. TMB for us, the choice to validate it, like I said, was motivated by wanting to bring a send-out test in-house because our oncologists were demanding it. But also, it provides one more biomarker that basically comes for free. We're utilizing data from the test that has already been run for a particular specimen. So it doesn't require more tumor. It doesn't require more DNA from that specimen. That data has already been generated. And in the case of these inconclusive results for the other testing, it provides yet one more either support for a positive result or a negative result. It's my understanding that the oncologists are not acting on those intermediate results. The action is taken for the highs. In our lab, at this point, we have about a 6% positive TMB high reporting. So that's that many cases that can be eligible for various study trials and or immune checkpoint therapies.
Great, thank you. And Studi, what about your experience with TMB? Tell us about what you used to do at Penn Medicine.
So it's not something, TMB was not something that was routinely reported out, at least for GI malignancies, and as far as I understand, not even for lung malignancies, just because there was not an FDA approval. What we would have at Tumor Board, we would have a whole host of different members of the clinical care team, including oncologists, geneticists, the folks who would run the molecular diagnostics lab, along with pathologists and multiple other clinicians. If any specific tumor had been tested and was found to have a lot of mutations, by the folks who ran the NGS lab, that was brought to the attention of the oncologist, saying maybe this person is a good target for this immunotherapy, and maybe something that you want to try out based on the patient's clinical habitus and whether they're eligible for this or not. So that is something that was done on a much more informal basis with regards to individual patients at Penn.
Great. So a lot of communication, obviously, in that collaboration. Mamatha, your experience with oncologists and TMB, are they asking for it?
So we send out our tests to foundation for CDX testing. Starting from July of this year, I have observed that they are reporting the TMB, and it will be on the front page, front part of the report on the right side of the corner, which is in bold. I did speak with our oncologists, at the time, if they're using the TMB, and this was before July, and they were not using any information from TMB, at least the community oncologists. But probably things are changing, and I do not know how they're using the TMB information and translating it to, are they speaking to the patients along with the PD-L1 data? I'm not sure about it. But TMB is being reported in the next-gen sequencing report. So they see it. It's very bold. And in our addendums, when we scan the reports, we are putting the TMB as a separate thing, and we are reporting the TMB. So.
Great. Yeah, I think, once again, right now, as of, October 2018, it's not part of any drug label, but we can certainly anticipate that it's going to emerge. And probably in spring of 2019, we can anticipate that TMB may get incorporated into some of these drug labels. Intentionally, we designed this panel discussion not to dive into the science around a lot of these really complex topics. ASCP has developed a series of online educational modules, and you can actually access them on pathologylearning.org or pathologylearning.org. And these learning modules are going to dive into the science. And keep in mind that the science may quickly get outdated as well. But in terms of ASCP developing clinical content, scientific content, we wanted to make it available online so that you all can spend time with your teams as well as to learn on your own. But I wanted to just remind everyone, this is something that came out in the New England Journal kind of as a response to some articles that had been published. And there was a lot of excitement this year around TMB and its correlation for lung cancer in the early part of this year with AACR publishing a lot of data. But essentially what this study shows is sort of the correlation of tumor mutational burden as well as objective response rate across all these different tumors. And one of the big challenges with TMB right now is what is that cutoff? What is the threshold? And what is that number of what we would consider high? Because depending on the study, it might be different. And even depending on the study, what you define as TMB might be a little different as well. But here you'll see, once again, you can reference this on the New England Journal website as to what they measured as well as how they correlated and saw, depending on the tumor type, how did patients respond based on what they considered high TMB. So with that, we're going to actually move on to MSI and MMR, and then we want to have questions from you all across all of these biomarker topics because as we can sort of think about, all of these things are interrelated. It's one thing, we lived a long time ago in an era where certain tests were just for lung and others were just for colon and others were just for breast cancer. And today it seems like these things really overlap, whether you've got urothelial versus melanoma versus breast. I mean, in 2 or 3 years, the kind of testing and the information that we use, it may not depend on the anatomic site. So the MSI as well as MMR, we're going to get into this in just a moment because of what happened last year. Many of you know that in May of last year, pembrolizumab, got its approval for this was the first FDA's tissue or site agnostic approval. And essentially the FDA said if you've got an unresectable or metastatic tumor, solid tumor that's either MSI high or MMR deficient, then these patients, whether they're adults or children, could receive this immune checkpoint inhibitor. And of course, there's a lot more details there. And when you look at this study and when you look at all the data that supported this approval, it was not just colorectal cancer. When we think of MSI high, we may think of colorectal or endometrial, but they also had other tumor types. So one question we wanted to ask all of you is, all right, this indication and this approval happened May of last year. In your institution, have you seen an increase of test requests for MSI or MMR testing? So it's been well over a year now. Have you actually observed a significant increase, moderate increase, no increase, or perhaps you're not sure? So take a moment now, pick up your keypads and enter your responses, and we'll see sort of what's happening here with this crowd. All right, let's see how people voted. Okay, very interesting. So about a third saying yes, significant increase or moderate increase. If we collectively combine that, that's close to 60% there. And then about a third saying, yeah, really not sure. Only 14% saying no increase. So I think the question becomes, for those of you who are not sure, it might be interesting to go back and ask the people who would know, have we seen an increase in either MSI or MMR test requests? So we're going to now sort of position a case for discussion, and we're going to say that suppose in your hospital you have seen an increase. And in fact, prior to the increase, you were primarily using MSI or MMR for colorectal and endometrial cancer, and you were looking for things like hereditary cancers and so on. Your cancer program director, your lab director says, you know what, should we be testing for MSI, MMR in many different types of cancers? We've heard in some instances where medical oncologists were asking to pull up samples from a few years ago saying, hey, I've got this patient who's got advanced stage cancer. Maybe we can see if this patient has high MSI or MMR deficient tumors. And so there's this question about okay, how much is over-testing versus, is there even a role for some kind of a reflexive testing process? Or should there be a set of criteria whereby a lab says, you know what, this makes sense. This is sort of, this is reasonable. We want to just spend a moment getting into some of the nuances and differences between MSI versus MMR. So just take a minute now and tell us about your level of familiarity. Sometimes we use these interchangeably, but they are not the same test. So how familiar are you with the differences between MSI versus MMR testing? And just take a moment to vote, and then we're going to have some panel discussion here in a moment. All right, so a couple more responses coming in. And let's see how people voted. So there's definitely, it seems like, some room for just providing a little bit more education about this topic. And as I mentioned earlier, pathologylearning.org, you can certainly dive into the details behind the IHC versus the PCR methods of testing. We're not going to spend too much time, but as I mentioned earlier, these are the two acronyms spelled out. And in the literature, when it comes to MMR at least, sometimes you'll see the small d, MMR for deficient, or the D might follow the MMR. So we're still living in an era where the way these tests are reported in different studies is not completely been standardized yet. But we also wanted to just mention that researchers have been asking the question of how often do we see MSI high tumors in different types of cancers. And even though this is not a comprehensive list, this is at least one reference point. In the parentheses, you'll see these were the number of patients that were studied across multiple different studies. So this is essentially a summary, almost like a meta-analysis, of all these different studies that looked at MSI high tests and looked at, okay, in what cases do we see high MSI, and in what cases is it extremely low or rare to find an MSI high tumor? And you'll see that, unfortunately, a lot of the common types, like breast, lung, and prostate, it's very uncommon, at least as of what we know today, to see MSI high. So with that, there's obviously a lot of issues here. Some of these, like I said, is an IHC test. Some of these are molecular tests. Most of the testing in the community seems to be relying on the IHC test. But what is the current landscape of MSI and MMR testing, and where do you see it going? This time I'll have Mamatha begin. So tell us about your experience out at Sutter.
So definitely our MMR testing has increased with the new approvals and stuff like that. So I see a concurrent PD-L1 and MMR testing being requested on the metastatic setting as well, and many solid tumors like GI and other tumors as well. We have been reflexively testing all the endometrial and colon cancers, we are not including the serous cancers. And I did check with Dr. Terry Longacre at Stanford. We had a dialogue, and at some point they were testing everything, but we kind of now eliminating the serous cancers. But the question comes when one of the things you were talking about, are we over-testing, under-testing these? What I see in our practice is that we are doing our MMR panels, and these patients travel to Stanford or UCSF, and some of these academic centers are repeating the MMR panels. And I did a quick review of all our cases of the patients who went to other academic centers, but the concordance is 100%. So, and regarding the MSI testing, we are using the foundation for the MSI testing. Definitely what I see in the community practice is that of all the next-gen sequencing PD-L1, MMR did pick up all the tumor mutation burden. MMR testing, MSI testing has picked up pretty fast, and among the oncologists, and the request rates have grown up in the last few months of this year, actually. So. But my only concern for that is that some of these metastatic settings, we have small sample. We do not have an internal control. And so that's something still we have to hear from other people's experiences, what we do with that problem yet. So.
Thank you. Lisa, what about you?
I think our hospital may be a bit unusual. We do primarily MSI testing, and it has increased, although not maybe as much as you would expect, but that I think is because we were in part participated in some of the trials. So our lab was we had the increase sooner perhaps. The problem with MSI, they routinely opt for MSI because we do provide that. The problem with MSI is it requires tumor normal testing, and that's not always available, especially with consult specimens where they don't submit a normal sample. In addition, it does require a certain tumor cellularity percentage and just quantity of DNA that if you have a very small tissue sample, that will occasionally be reflexed to our MMR test. I'm not sure what the other questions are.
No, that's great. And we'll spend a little bit more time diving into some of these things because obviously there's overlap with molecular testing and some of the NGS that we were talking about earlier. Studi, what's been your experience with MSI and MMR?
So at University of Pennsylvania, we used to do MMR testing much more frequently than we did MSI testing. And with regards to the increase in volume, just since the approval and since clinical trials were in progress, we have seen a dramatic increase in the number of specimens that were coming in for DMMR testing on a routine basis. Those were stage 3 and stage 4 cancers. And also what we found was that this testing was being requested on a one-on-one basis. Off late, they have been paired with requests for PD-L1 testing in the approved tumor types. In terms of, so there was a dramatic increase, and then there's been a certain plateau. We tried to do a little study to see what proportion of these patients were actually getting to the immunotherapy that this testing was being done for. And what we found was that a very small number of tumors in the single digits were actually showing DMMR loss of protein expression. And of those, even smaller numbers were being actually utilized for administering the drug. And I think there was a whole host of clinical factors that would play a role in terms of what patients actually got to receiving a therapy. So I think as far as until there's a better biomarker available, DMMR has been available for a very long time. It's a cheap test. I think it's going to continue, and there is going to be requests from the clinical side to do this testing. So I think it's here to stay, but if better biomarkers are available, maybe this test will be one of the several tests and not as prominent as it is at this point of time.
Thank you, Studi. We want to open it up to you all now and hear from you. Several of you have said, yeah, MSI, MMR test requests have gone up in our own institutions. If you come from a center where that was the case, has that been an experience where you've now been able to identify more patients who are eligible for treatment? Or has it been more wasteful in your experience? So we'd love to hear that perspective. We'd also love to hear, how have you been able to navigate perhaps the different requests made by medical oncology? And because some of these things overlap with the next-gen sequencing, we kind of wanted to lump this part of the discussion together. So with that, anyone in the room want to share either your experience or ask a question to the panelists? If you could raise your hand, we'll send a mic to you so that we can hear your question or your comment. Anyone? Okay, we've got one here.
Yeah, we've had to limit some of the testing that the oncologists can order. Basically, for pretty much most of the major cancer types, we have kind of a standard algorithm now, which is based very heavily upon what NCCN treatment recommendations are. And they kind of spell out, you know, that this is what we do and what we don't. Sometimes we have a couple oncologists who have their own practice who like to send for other stuff, and what we end up doing is telling them, you know, we'll send the block to your office, and if patient wants to pay for it, you can send it from there, but the hospital's not going to send it out. Mm-hmm. In order to control costs, the days of anyone can order whatever they want, they're over.
Any reactions to that comment, or?
I have a question. So you're sending the MMR panel out to a laboratory for testing or in-house?
No, I'm sorry.
Things like the next-gen sequencing?
Yeah, like for next-gen sequencing.
Okay.
Yeah, MMR panels we do in-house.
Okay. So, okay.
Anyone else with a question or a comment? Because I want to also ask the question to the panelists. You know, you've seen this slide, and there are similar slides out there like it. But based on our kind of limited knowledge, and I think we all have to admit that, you know, we still have very limited knowledge about much of this science because we're still gathering data. But if we look at something like this and look at, okay, when are we likely to see MSI high versus when is it very unlikely to see MSI high? Do you find that slides like this and data like this will help convince oncologists to be more mindful when they're ordering tests? Reaction from the panel on slides like this, or just other mechanisms to sort of think about, you know, over-testing versus appropriate testing? Studi.
In my opinion and in my experience at University of Pennsylvania, it has been that when the clinicians are out of therapeutic modalities and they're looking for a biomarker that might justify therapy for a particular patient, irrespective of the tumor type and irrespective of the data, they will request the testing to see if they can, the clinicians can provide a specific therapy that has been approved by the FDA. So I don't believe that awareness of this data, and the oncologists are certainly aware of this data, will limit their request of testing, at least at large academic centers where clinical trials are in progress.
Mamatha, what about your perspective from a community setting? Do you also find that in many cases they're ordering tests when they're looking for that sort of salvage therapy or third line, fourth line options?
So I would divide this organs into different ways how the oncologists are looking at the community level. So it would be non-GI versus the GI, and also separating the gynecological tumors out separately. So I'll explain why. Because the metastatic setting of the non-GI areas, we have seen an increase in the requests. And I do agree with Dr. Shroff that probably this is the end of the life treatment. You know, they're looking at the metastatic setting. So that's where I see an increase in the requests. The GI component has been traditionally, you know, we were doing that, and colon, but what I'm concerned, being a breast and a gynae pathologist, is that I spoke to a few of the gynae oncologists, and we are doing this reflex MMR testing on these patients, and they do not know how to use this the data. So, you know, And unless you have a metastatic ovarian tumor, then we have the NGS, we have this MMR. That's when an oncologist comes in and looks at it. But the gynae oncologists need to be educated more on, when they have to, or how to use this data. So.
And I would just add to that, we have had an increase in gynecological, specifically endometrial tumors. And with regard to MSI, the shifts that you see are much more subtle with endometrial cancer relative to colon cancer. And interpretation is not as easy. And so although we haven't, in our lab, necessarily seen an increase in overall testing, in going through the data, I did see a very slight increase in that C findings or inconclusive type interpretation, where a shift was seen, but a clean MSI high or a clean call wasn't able to be made. So, to put that in perspective, if this is a kind of reaching for straws effort on a tumor type that isn't well validated with a particular method, it may just be money poorly spent, because if your result doesn't have the confidence of a well-validated result, you're not serving the patient.
I know, Lisa, in your instance, you work within the Hopkins Molecular Lab, but you provide services both to the main hospital campus of Hopkins, but also the community hospitals. Would you say that there's been a trend of differences in terms of the types of molecular tests that are ordered from what I'll call the mothership, right, where you're doing a lot of research, different clinical trials, versus those community hospitals where you've got either private medical oncology groups? Are there trends or differences in terms of how they're ordering molecular tests and even things like MSI?
I think the biggest differences we see is sometimes FFPE quality for the tumor types. I think in-house we have kind of standardized fixation methods. I'm sure every institution has standardized fixation methods, but we have validated our tests around the in-house blocks that we've validated off of. And so when we are receiving consult cases or samples from our satellite hospitals, we do notice some deviation from institution to institution as far as the quality of results.
Okay, great, thank you. Other questions from the audience? Yes, go ahead.
How is helping the survival of patients according to the clinical trials you're running?
So the question is link survival outcomes?
Yes. This positive test high burden tumor and survival of patients.
The clinical relevance, unfortunately.
Can you pick up the mic, Lisa?
I'm so sorry. With regard to TMB or MSI,
Both of them, or whatever you consider is more significant.
unfortunately, our lab does not always get the information about therapeutic treatment that our oncologists make. And so we do have ongoing prospective analysis of that data. It's a new enough thing that we haven't accumulated enough data, but it's actually very difficult in our institution to link our reporting of test results to therapeutic decision-making by the oncologists. And that's actually, in my opinion, that communication breakdown is slowing this process. Because we don't have working groups. We do have a tumor board that does some interaction, but that's a case-by-case basis. So collecting large amounts of prospective data to look at clinical relevance is a real challenge.
Yeah, and I think the question is really getting at issues like, do you have access to what was the patient treated with, and then what was the survival outcome? Like, what was the actual patient outcome? And that EHR data for the patient side may not necessarily connect with the pathology information system. And so pathologists are often left in the dark, and we're kind of working in our silos. Mamatha, were you going to make a comment about that? Or?
Yeah, no, I thought that we don't have in individual hospital data how these patients, as Joe said, maybe we need to prospectively collect them. But if you look at the Checkmate trials data, that's something that you can refer to on the PDL1 and MMR or MSI high, how these patients have done in the clinical trials. Those are some of the places where you get information on to get a general feel, of it. So.
And Studi, were you going to make a comment? Then we'll get to you in just a moment.
Yeah, so as I alluded to, we did a little study with our residents just within pathology to see how many of the tumors we got a dramatic increase in the requests for testing, and what proportion of those tumors were actually DMMR. We found that these were within the single digit percentages. Of those, how many of those actually got to receiving the therapy, and how many of those were actually completion of therapy and actually called a therapeutic success. Our numbers were very small, but I will say that for all the there were about 6 or 7 patients of about 150 patients that had DMMR tumors across various different tumor types over a course of a couple of years, and only 3 of those were actually administered the therapy, and of that, only 1 of them was found to have a good outcome and completion of therapy. For a couple of the other patients, for a variety of different reasons, they did not actually complete the therapy. So I think the completion of therapy and success outcomes are still at this point of time being determined, but as Mamta alluded, the Checkmate trials are a good reference source for that.
Now, before we get to your question or comment, I do want to warn everyone that our cell phones, I think, are about to go off if this emergency alert actually works. So while you're asking your question or comment, please be mindful that if your phone goes off, just to silence it. But go ahead.
I wanted to make a comment before I have to leave because I'll be on the next panel. One of the things that we found helped is we have different disease teams for different areas. Like I'm on the neuro-oncology and the head and neck oncology, because you really can't be an expert in everything. And so, we started this with neuro-oncology, and so we had radiologists, neurology, neurosurgery, rehab, speech, etc. And it really has to be part of a whole one organic thing. And what we ended up doing was meeting at one of the nice restaurants in Lancaster, and we all said, okay, we're going to sit here, and over dinner we talked about John Doe came into the emergency room with a headache and blah blah blah, and turns out has a brain tumor. And we just went step by step by step. Are you gonna prophylax with Kefra and and then you go down through and all the testing, and we ended up basically doing that with every tumor. And what you find is then
Those might be the alerts. So.
Yep.
So we appreciate you silencing the alerts, and we know that the system works.
Well,
But go ahead.
I'm
Please
glad I
continue.
didn't have my hearing aids on when that went off. But no, it was. But I think that was it took a long time to work through that, but just step by step. And you find that there's a lot of communication. Like the first question somebody asked, do you prophylax with Kefra? And I'm like, what's Kefra? So there's a lot of learning that goes on in this whole process, but that's what we did. So
Thank you for that
if you want to
comment.
hear more about that, next
Yeah, well, I think we realize that, because of how quickly the science is changing, it's very difficult, for instance, to even come up with an institutional testing policy on some of these issues, because the minute you come up with the policy, it's already outdated. So in many cases, it's coming up with the structure and the means of developing that policy and that procedure. But we recognize that because there's so much happening, ASCP has formed that educational task force. We want to provide this education and continue to provide updates. And I guess one question that I have for the panelists, it's almost like a closing thought now as we think about the future, is as you anticipate 2019, okay, thinking about next year, which is only a few months away, what do you think are going to be some of the biggest changes that will happen as it relates to immuno-oncology, the use of these biomarkers? And this, sort of a related question is, how do you think your institution will tackle that change? So what do you think is going to be the biggest change in 2019? How do you think your institution will tackle that change? Mamatha, if you'd like to begin.
That's a very difficult question, but I'll try to answer that from the community practice level, so which is very important too. 3 years ago, or even 4 years ago, when the PD-L1 just hit the market, I asked the oncologists in our practice that, are you going to be ordering PD-L1? Do you want me to look for a laboratory who does the PD-L1? Do you want us to send it out? And the response was that, I don't care for PD-L1. It doesn't matter for me, for my patients, and that was the response. And fast forward, I see an increase in the PD-L1 requests from the oncologists, and they're more aware of it, and they're sending out PD-L1 for a lot of tumor types. So definitely the education component from the oncologist to the pathologist has increased, as we are discovering all this new stuff that's coming out, the data. But to me, the implementation is still an issue in the community level. Because of the reimbursements, as you have mentioned, all these are going to be still challenges faced by the pathologists in the community practice. So I think in 2019, what I see is that having the pathologists, proactively working with the oncologists as the new data comes out, it's easier for them to explain to the oncologist much better than just without any data out there. So, those are the things that are going to be improving. And I feel like 2019, we are going to see a lot more from the CAP to direct us. And I do know that they're kind of working on a PD-L1 proficiency testing if you bring it in-house as a laboratory developed test. So these are some of the things that we need to talk to our oncologists. And so I think it's very promising in 2019 where we had. So
Great, thank you, Mamatha. And Lisa.
I think with the approval of a tumor agnostic therapy, I think that that's going to just blossom in terms of the basket trials that are out there. And I think going forward, it's likely that the guidelines are going to be shifting away from tumor type and towards molecular mutation type. I think that's going to be a big challenge for our labs and our hospitals. From an education standpoint, from a validated test standpoint, I think there's going to be a big move in that direction. But I think we're all working in a very fast-moving, fast-changing environment, and the level of ongoing education and communication between all the different people in the medical system is going to be integral. If you don't have that, you can have a wonderful test. If it's not used or understood, it's of no value. Or you can provide testing for something that does not translate to a therapeutic, helpful situation for your patient. So going forward, I think education and looking at the changing guidelines and the changing approaches towards treating cancer.
Sure, thank you. And Studi?
I think I'd like to echo what has been said by Mamta and Lisa, and maybe add that I think that 2019 and going forwards, there is going to be a lot more testing that is going to come across. Hopefully we'll have better biomarkers, better designed biomarkers that are more accurate in predicting which patient is actually going to be responding to the therapy that we're testing for. I would hope that of the existing biomarkers, some of them actually come out and prove to be better determinants of response to therapy. At this point of time, we're still trying to narrow that out. And the site agnostic testing hopefully will be narrowed down to have a more specific indication for which would be the testing that should be done for various different tumor types. I agree with Lisa that this is going to stay site agnostic and is going to depend upon the tumor mutations as opposed to a specific mutation. In addition, just on a much more broader scale, there's a whole lot of trials that are going on that talk about immunotherapy in combination with other therapies. And I see that more and more that it's going to become this forefront of how patients are going to be managed. But from a pathology perspective, I think it's very important for us to be aware, and that awareness is definitely increasing, and I hope it continues to increase within the coming years.
Great. Thank you very much, Stuti. Yeah, I think we're living in a very exciting but also very chaotic time. And, with things like Medicare's approval of NGS testing, we can certainly anticipate more testing, more molecular testing, and that sort of blends into all the other biomarkers out there. But also when you go to the FDA's website and look at all the recent drug approvals and indications, we see not only new drugs, but just expanded indications. So I think 2019 is going to be a year where we're going to see more and more changes. But unless we're proactively thinking about these, as well as knowing how we're going to navigate them within our own health systems, we're always going to be in sort of this reactionary mode, trying to catch up with the science, catching up with the data. And it's our hope that you all will proactively go back to your own institutions, learn more about this, engage with your medical oncology colleagues and your clinicians and your administrators, and have more of these discussions as a team, so that as a group and as a team you can establish consensus, get that kind of buy-in, and effectively make policies and procedures that are going to work for you. So with that, I want to thank everyone and thank the panelists. And if you've got questions, then we will be around. But thank you so much for being here today.